Well, hello everyone, and happy Mother's Day and National Women's Health Week. I pray that you are staying safe and healthy amid this new reality of COVID-19. My name is Laura Kigweba James. I am the organizing program coordinator at the General Board of Church and Society of the United Methodist Church. And today I am here with mother, grandmother, maternal health advocate, and United Methodist, Dr. Kathy Hartke, OBGYN, to discuss how we as United Methodists can celebrate Mother's Day and National Women's Health Week by taking action to save mothers' lives. As many of us know, the COVID-19 pandemic has revealed countless social and economic disparities. In the US, these disparities have been made clear by our burdened healthcare system. Dr. Hartke, can you share with us the challenges and impact of COVID-19 on mothers and their babies?
Well, thank you, Laura, for inviting me to participate, and thank you for all the work that you are doing at Church and Society. COVID-19 is such a difficult time for everyone, but particularly for pregnant mothers, and we just don't have enough data to understand what best practices should look like, and it's changing every day, which is part of the concern and drives so much stress for pregnant moms and new mothers. One of the problems is that we're worried about transmission, and we're trying to keep mothers safe during the pregnancy. So all the physical distancing, wearing a mask, hand washing is really important. And that also goes into changes when they arrive at the hospital. Some mothers are being tested just prior to being admitted for elective procedures, but when they arrive to the hospital, if they're in labor, they will be asked questions, as every person being admitted to the hospital would be, and they're asked to wear a mask. And then we are recommending that all mothers that are admitted have a test for COVID-19 to know if they are carrying the infection, both for themselves and for plans for their infant, but also to protect the healthcare providers. We know 17% of healthcare providers have been infected. And so this is a critical time for everybody. We also have problems with isolation when a mother is determined to be positive. We don't know what the best treatment is. And at some points, it was recommended that they be separated from their newborn infant. And now we're using a method of joint decision-making with the mother and the providers. And in many cases, the mothers are choosing to be with their newborn, which is very important for bonding and for feeding the baby with a mask, hand washing, and doing all the protection possible, but being able to be with your newborn baby. When they go home, some recommendations were put out that they should go into an environment where there was someone who was not sick with the infection. However, again, we need to keep mothers with their babies, and whenever possible, this should be the approach that we're taking. We're also worried about depression in moms because the birth experience is not what they had planned. Some mothers, for example, in New York, were being told that they could not have a support person, not even their husband or the baby's father. And some of those women in New York were actually leaving and going to other states. We had one woman that came to Wisconsin after finding 3 different birth hospitals that would allow a support person. And we don't recommend travel from state to state. And hopefully that hospitals are allowing a support person and even a partner and a doula, because many women depend on a doula for their birthing process. We're concerned about incarcerated women who are at much higher risk for being infected. And there are many women in jail. 70% of them can't afford bail and are there even before they've had a trial or a conviction. And those women should be protected by not remaining in the jail if at all possible. And we know that the majority of those women are nonviolent people. So we hope to get mothers home with their other children before Mother's Day.
The impact of COVID-19 has impacted so much. At the same time, it is revealing so much. I'm reminded from a webinar that I heard a couple weeks ago from the interim director of the Black Mamas Matter Alliance, Angela Ina, who stressed that the COVID-19 has amplified health inequities in the US that have already existed, and it has also intensified our maternal health crisis. And Dr. Harkey, you and I both know that when it comes to the maternal health, the US is ranked as one of 13 countries with the highest cases of maternal mortality. And these cases are higher in Black and Brown and Indigenous communities, like you've shared. So, as a healthcare practitioner, when in your career did you become aware of these health disparities in maternal health? And how has this knowledge informed your work and your advocacy?
Well, even as a young child, I was aware of our church missionary in um, Africa, and she was a nurse midwife and talked about the disparities between the African women that she cared for and the US. And then when I became a resident after medical school in 1983, I started my training at a Jewish hospital that was founded in 1903 for Jewish immigrants who had no money, and the Jewish doctors could not get privileges at other hospitals. And this hospital is in the central part of downtown Milwaukee and cared for many wealthy women and women from the east side near the lake, but also was right there where the Black community in our city is. And in Milwaukee, we have the most segregated city in the country. So it was quite drastic, the differences that I was seeing. There were many women who had chronic health diseases because of poverty and the stress and trauma from child adverse events, as well as racism. And chronic hypertension and diabetes were not uncommon. We also had a teen clinic with adolescents up to age 17. And without having education and access to care, we were seeing many young women and Black women or Black girls who were pregnant at the time. We would have social workers that went to the homes and found out that they didn't have electricity, or they had lost their apartment and had to move, or maybe were homeless. And sometimes they had to put milk out on the windowsill in the winter time because they didn't have refrigeration. There were so many problems that we saw that were just not acceptable. And I used to think at night in the call room about how we could change this this whole system, this problem that we had with the disparities that I was seeing. And I grew up in the Methodist Church where we were taking action. We wrote letters to our legislators, and I developed skills in advocacy so I could testify in the legislature and testify in court on behalf of patients, and now work with organizations like the Perinatal Quality Collaborative in our state that's trying to end this disparity and save mothers' lives.
And thank you for your continued work and being with us today. And I mean, what you've shared opens up this reality that racism is a system that impacts so many lives, specifically mothers and their babies. And Nurse Hakima Payne, co-founder of the Uzazi Village, which is a community-centered maternal health organization in Kansas City, Missouri, talks about the system of racism and its impact on maternal health. And she says this, that closing the maternal death gap is uniquely challenging as research increasingly shows that the disparity is less an outcome of clinical practices, but of systemic racism and bias. And right now, there is a proposed federal legislation that will address racial disparities and improve maternal health for all through the Black Maternal Health Momnibus Act of 2020. Dr. Harkey, can you explain for us of how the Momnibus Act will address racial disparities and be improving maternal health?
Yes, well, I'll start by explaining the Preventing Maternal Deaths Act that United Methodists advocated for in 2018, and with other medical organizations, we were able to get that passed in December of 2018. It provided $52 million to the Center for Disease Control for maternal mortality review teams to um, increase their staffing and to actually start maternal mortality reviews in the 15 states that didn't have committees that were reviewing those deaths. By doing those reviews, we're able to make recommendations as to how to improve at every level, whether it's the hospital, the physician providers, the system, or legislatively, where we can change how we treat women so that we can prevent maternal deaths. And so we've made huge progress. Now, the next step is our 2020 Black Maternal Health Omnibus Bill. And we'll take a look at that on the slide. An omnibus is a package of bills, and this one was introduced by the Black Maternal Health Caucus in March. It's a package of 9 bills, and it builds on what we've done with the 2018 Act. It's bipartisan and bicameral, and so for people that are new in advocacy, that means that it's both supported by Republicans and Democrats, and really maternal health and saving lives should be a totally nonpartisan issue. And it's co-sponsored by members of both the Senate and the House. So we have many people on all sides working on this issue. It advances maternal health equity and addresses implicit bias and explicit bias and racism. And so with some of the parts of this will address ways that we can teach healthcare providers and improve how we interact with people, and hopefully treat everybody equally and erase some of this inequity that we see. We know Black mothers are dying 3 to 4 times the rate of their white counterparts. In Wisconsin, a Black woman has a 5 times greater chance of dying than a white woman, which is just unacceptable. And we have to find all the ways possible to end this disparity. The goal is to end preventable maternal mortality and close the racial and ethnic disparities. There's 2 parts, 2 specific bills that we'll talk about. The HR 4995 is the Maternal Health Quality Improvement Act. This supports training programs so that my committee, I'm the co-chair of the Maternal Mortality Review Team in Wisconsin, and we are instituting training for implicit bias for all of our committee members. But it would, some states like California have already passed laws that require all perinatal providers to have implicit bias training to improve their competency. And New Jersey is on its way to passing a similar law. This bill also would invest in the Alliance for Innovation in Maternal Health. This is a group of patient safety bundles, all of which include looking at disparities and equity at every step. And these are a series of recommendations for how we treat certain problems like hemorrhage in a mother who's just delivered, or hypertension, so that we all are using the same criteria and the same treatment decision-making for all women, whether you're at a rural hospital or a high-level hospital, and regardless of ethnicity, everyone would get the same treatment. It also supports perinatal quality collaboratives. So the maternal mortality reviews get data that suggests that certain problems need to be improved on, and this then goes to the perinatal quality collaboratives, which do quality improvement projects. And we're going to be starting our newest one in Wisconsin on maternal hypertension, so that every woman gets the same treatment and gets follow-up after she delivers. The next part is for improving access to OB care in rural areas. We now have rural residency training programs, and we're developing a network where we have identification of the level of care that each birth hospital can provide. If someone needs higher level care than their critical access hospital or rural hospital, they would be referred to a hospital that is capable of managing a high risk pregnancy so that no one has to deliver in a place that can't provide the optimal care. This might require transport, and it's helpful to know which hospitals are nearby and have a system where there's communication in both directions. We also want to increase access to telehealth. So if you live in a southern state where many of our Black women live in rural areas, they can't get to the hospital easily or to their regular visits because the distance is maybe an hour or more away for travel. Some visits can be done via telehealth, and it saves that transportation and also increases the frequency of visits that might be needed. So these are all important things. And some of them, for example, telehealth has actually been brought to the forefront with the COVID-19, and things that we couldn't get past for the last 5 years, reimbursement for telehealth and even allowing telehealth to be done has now happened in a very rapid fashion. So there are some positive things that have come out of the pandemic. The next bill is H.R. 4996, the Helping Moms Act, and this incentivizes states to adopt 12 months of continuous postpartum coverage. Some states already have this. My state of Wisconsin has not adopted this, although we tried very hard to get that, but it's important for mothers to have continuous coverage after they have the baby and before they have the next baby. We know Medicaid covers 43% of all births in the United States, and many Black women depend on Medicaid to have birth coverage and obstetrical care. But for some women, they get the coverage during the pregnancy because they change the requirements, and then if they don't meet the higher poverty or the lower poverty level after they deliver, their Medicaid coverage can end at 60 days postpartum. This is a really serious problem because we have women that might be identified now as being hypertensive or having diabetes. Maybe they've developed a mental health problem like postpartum depression, or if they've had substance use treatment during the pregnancy and now their coverage ends and they can't get to the doctor to have ongoing counseling or medical treatment, or they can't continue their medication, they are at high risk of having a complication. 33% of all pregnancy-related deaths occur from 7 days after delivery to 1 year after the baby's born. And mothers can have many problems that cause them to die or have close near-death experiences which result in long-term complications. And we're seeing a rise in deaths from cardiovascular disease, overdose, and suicide 6 to 12 months after delivery. We saw a report in the news in January of this year in our city of a young Black woman who had delivered a baby 10 months earlier and had shortness of breath, chest pain, went to the emergency room, was not seen for 2.5 hours. During that time, she kept asking to be seen. She was posting on Facebook and Twitter, very anxious, and was told that it would take several hours more before she could be seen. She left and went to an urgent care to receive care and died there. This should never happen. If someone is in the 12 months since they've had a baby and they have those types of symptoms, they should be seen immediately. And we have to, stop that type of care which is inadequate and help stop um, the deaths that are preventable. So there's many things that can come out of these two bills in particular, but there are other things that are in this omnibus package that we'll be addressing as time goes on.
Dr. Harkey, thank you. Thank you for your time, your expertise, and leading us with this call to action. And happy Mother's Day to you. Thank you for how you're calling all of us to save mothers' lives. And Kathy is right. We at Church and Society will continue to uplift maternal health care in the weeks to come. And I encourage all of you to visit our website at umcjustice.org on our Faith in Action blog, where we will be having conversations around maternal health when it comes to justice for incarcerated pregnant moms, as well as a call for comprehensive, equitable reproductive health care for all. As United Methodists, we affirm that all people are of sacred worth. As we celebrate Mother's Day, let us take action and save mothers by calling our members of Congress to support the Black Maternal Health Omnibus Act of 2020. This will address racial disparities in maternal health and improve health care for all of us. Again, thank you, Dr. Harkey. Thank you all, and we'll talk to you soon. Bye.